Hello everyone. So today we will be seeing the NEET-PG 2024 recall in the subject of pediatrics. I am Dr. Singaram, your pediatrics faculty. We will get started with the session today. Before we start solving the question, I wanted to give an overview of how the questions were asked in the subject of pediatrics. This time it was a standard paper with questions including the familiar topics only, but most of the questions were little bit in depth, but it was solvable type of questions. So if you have understood the topic properly, it was easy to answer the questions from the pediatric section. It was conducted in 2 sessions. I will be discussing the questions and I will start first with the session 1. Towards the end, I will be discussing session 2, but also there are few questions which we were not able to correctly identify it was session 1 or 2. So I have also grouped them under session 2 only. So let us get started with session 1 questions. This is the first question where it is below is the growth curve of 3 children. Which of them indicates growth failure? So it was a question based on the WHO's growth curves of 3 children, which was marked as 1, 2 and 3. So let us see the charts. This is weight for age chart for girls, that is why it is pink in color, and you can see the 3 curves which are marked. If you look at the curve 1, okay, this one I am talking about, curve number 1, the growth trajectory is between 0 and plus 2 standard deviation. This is absolutely normal growth for the child. 0 to plus 2 standard deviation means normal growth. So there is no growth faltering here. Now we move on to the curve number 2, okay, right, the green colored one. Here you can see the trajectory is between 0 and minus 2. Now you have to tell whether it is normal or abnormal. This is again considered to be normal only because any value below minus 2 standard deviation only is considered to be low values or abnormal values, okay. But the curve number 2 clearly tells you the trajectory is between 0 and plus and minus 2 standard deviation. So it's going to be a normal one only, okay. Now look at the third one, the third curve here, okay. Here you can see initially the trajectory was normal, but towards the end you can see that there was growth faltering. Why I am saying growth faltering? Because I will mark that particular area. You can see that the growth was faltering means the weight was on a decreasing trend. It was not keeping up with the percentile. And you can see the final value is going below minus 2 standard deviation. So definitely curve number 3 indicates that the child is having growth faltering. So going back to the option, you can see that option D has only 3 and that would be the answer for this particular question. So this was a question which was basically testing you about the application of WHO growth chart in growth monitoring in children. Growth failure or faltering refers to a value which is below minus 2 standard deviation. In that, curve number 3 only was fitting and hence it is the answer for that particular question. Moving on to the next question. A mother brought her 2-year-old child to the OPD with the complaints of lack of weight gain, abdominal pain on eating and poor eating habits. The child was advised gluten-free diet, after which there was improvement in the general condition and weight gain was noted. What is the probable diagnosis? Here, the only or the most important clue for your answer is advised gluten-free diet, to which the child showed improvement. Now, I think it's a very easy question to answer. What will be the answer for the question? It is nothing but celiac disease. Because celiac disease, or also called as a gluten hypersensitivity, is the condition that would respond to gluten-free diet, okay, and that will be the answer for this particular question. It was a very straightforward question. During our regular discussion itself, I told you how do you make a diagnosis of celiac disease. The diagnosis can be suspected based on the abdominal symptoms like abdominal pain, not able to gain weight or failure to thrive, chronic diarrhea. However, to make a diagnosis, you need some investigations. Initial testing would be antibody testing. What is antibody testing? It is estimation of IgA levels along with one more antibody. What is that? Anti-tissue transglutaminase antibody, TTG, anti-tissue transglutaminase antibody. Now, if the levels are elevated, I am putting positive, meaning if the levels elevated, you have to confirm your diagnosis with the next antibody testing. What is the next antibody testing? Anti-EMA. What is that? Anti-endomycin antibody, or you can do a biopsy to confirm the diagnosis. This would be the set of investigation required for making a diagnosis of celiac disease. Of course, one more thing which is required is definite response to gluten-free diet also will help you to confirm the diagnosis that it is only celiac disease. So, because of gluten-free diet, which was clearly mentioned in the question, the answer to this is celiac disease. Some students were recalling that there was also one more question related to the testing of celiac disease. As I have already told you in the previous slide, this slide only, there is IgA testing along with anti-tissue transglutaminase would be the initial testing for suspected celiac disease. This was a probable question which many students were able to recall. Okay, anyway, so for the second question, the answer is celiac disease. Moving on to the question number 3, what is represented by each of the following curve? I am going to put up the curve. It is something related to the pattern of growth of different tissues in the body. Okay, that's why you can see A, B, C, D, liver, spleen, ovary, genital organ, all those things are given. Let me just put up the curve. This is called as the Schemon's growth curve. Can you see that? This is called as the Schemon's growth curve, where age is in x-axis and percentage of the adult size is in y-axis. You can see the curve number A. Curve number A, you can see that it is a parabolic curve. Can you see that? It's like a parabolic curve. Initially, there was a steep increase. After that, there is a slow increase. If you see, this is something like till 2 years, almost like 90% of the value is attained. So now tell me, which part of the body attains 90% of the growth by the age of 2 years? It's a very easy question to answer. It is brain growth. Okay. Now, let us look at the curve B. Okay. What does the curve B indicate? That the value is going above 100%. That means what? Some part of the or some tissues in the body grows to more than 100% of the adult size, then again comes back to 100%. Okay, right? So, which part of the body grows like that? Growing more than the adult size, then again coming back to the adult size, and it is typically between the age of 4 to 8 years. Typically between the age of 4 to 8 years. Which one? Yes, it is the lymphoid tissues. Lymphoid tissues would include areas like tonsils, adenoids and lymph nodes. They are going to have this pattern of growth. Then next one is regarding the curve C, this one. Now you can see that it is a sigmoid curve. Can you see that? It's a sigmoid curve where initial 2 years there is a rapid increase, then there is a slow increase like this, then again after say like around 12 years, again after 12 years like that, there is again a rapid increase. So what is this sigmoid curve? C curve, it is for the somatic growth. Somatic growth. Okay, or simply you can remember like height increase pattern. Okay, then the last curve, the D curve here, till 10 to 12 years it was remaining silent, then it was rapidly increasing in size. What it could be? It is nothing but the gonadal growth, gonads, gonadal growth. So these are the 4 patterns of growth, which is what we call Schemon's growth curve, A, B, C, D. A is brain, B is lymphoid tissue, C is somatic growth and D is gonadal growth. So among the options, option D will be the answer for the question, because you can see very clearly it is written A is brain, B is Valde's ring, which is nothing but the ring of the lymphoid tissues, or some students recall the B as tonsil. Both are correct only. C is somatic growth, that is what I told you, height increase, and D is the gonadal growth, which includes the testicular growth. So option D will be the answer for this particular question. Moving on to the next question, an adolescent presented with a fever, purpura on the thigh, swelling of right knee and left ankle, abnormal diastolic murmur. Sorry, here it is abnormal diastolic murmur here in the cardiac apical area. The child was seronegative for rheumatoid factor. What is the probable diagnosis? So you can see that important clues are fever, okay, purpura may or may not be related. Let's keep that by the side. One more is the swelling of the right knee and the left ankle. That means it is a multiple joint involvement or arthritis which is noted. Along with that, there is a cardiac involvement also in the form of a murmur. It is also mentioned that he is seronegative for rheumatoid factor. So now you can see which fits into the diagnosis, mainly because of the clue that cardiac involvement, because all the things can have, all the options can have cardiac arthritis like seronegative arthropathy, rheumatoid arthritis, juvenile osteopolyarthritis, but only acute rheumatic fever will have joint involvement plus cardiac involvement. This is a well-known fact for most of us, and that should be the answer for this particular question as well. Okay, right? In fact, if you remember arthritis, cardiac involvement, if I write carditis, These are two major criteria which we use in the Jones criteria for diagnosis of rheumatic fever, okay, right? Arthritis and carditis. Quickly recollect, what is the Jones criteria for diagnosis of rheumatic fever? It should be 2 major or 1 major plus 2 minor, or in case of recurrences even 3 minor criteria. If you take fever, fever itself is one of the minor criteria in the Jones criteria. So definitely this question fits into the diagnosis of acute rheumatic fever. Now in this question, the diastolic murmur which is noted in the question could be a manifestation of valvulitis, which can be a part of cardiac involvement in rheumatic fever. And this is a classical murmur associated with mitral valvulitis. And what is the name of the diastolic murmur called? It's called Carey-Coombs murmur. Okay, Carey-Coombs murmur. So, fitting all possibilities, the answer for this question is acute rheumatic fever. Okay, right. Moving on to the next question. A neonate has bilateral chorioretinitis and intraparenchymal calcifications in the brain. Okay, it's a diffuse intraparenchymal calcifications in the brain. The baby also has hydrocephalus. What is the causative organism? The clue for this question is it is one of the torch infections characterized by these findings in the neonate. And the three features, chorioretinitis, diffuse parenchymal calcification, and third is hydrocephalus, itself is a triad of which of the following organism? Is it toxoplasma, trypanosoma, tinea solium, or cytomegalovirus? It classically fits into toxoplasma gondii infection. Okay. So remember, during the regular class itself, we have discussed this. Congenital toxoplasmosis, the triad is chorioretinitis, diffuse intracranial calcifications, and hydrocephalus, which is exactly what is given in the question. Now, tell me, what type of ELISA test helps in the diagnosis? ELISA test is for the detection of antibodies, that is understandable, but which antibody is more sensitive compared to the other? We have two things, IgA and IgM antibody testing. It is found out that IgA is a better test compared to IgM ELISA in this situation. That can also be a potential question for you. You should note that point. So, because of the triad given in the question, the answer is Toxoplasma gondii. Moving on to the next one. A 4-year-old child has petechiae and splenomegaly on examination. Lab investigation showed hemoglobin of 7. There is anemia. WBC count is 50,000. So, WBC count is elevated. And platelet count is 60,000 per cubic millimeter. That means there is definitely low platelets or thrombocytopenia. Okay. Acute leukemia was suspected. That is what is the next part of the question. Acute leukemia suspect. Okay. Now, in children, acute leukemia have two types, AML and ALL. What is the most likely diagnosis here? It is ALL, because that is the overall most common leukemia in children. Ideally, it should have been given that bone marrow showed more than 25% of lymphoblast. Then only we can make a sure diagnosis of acute lymphoblastic leukemia. But I assume that this was the question, and based on the given information, we can say acute leukemia is a possible leukemia in this particular child because it is the overall most common. Treatment of this condition should have a regimen containing which of the following? Okay. IVIG, prednisolone with vincristine, doxorubicin plus isorubicin, and radiotherapy of lymph nodes. Usually remember, we treat with chemotherapy only. So, IVIG is not an option and radiotherapy is also not an option. It has to be either B or C. Now, this is based on the knowledge of treatment of acute leukemias only. In the treatment of ALL, okay, what we start first is called as a induction phase. And the induction phase treatment will include typically 4 drugs, namely prednisolone, vincristine, L-asparginase, and anthracycline. Now, in our question, if you see the second option, it was containing prednisolone and vincristine. So, it is a treatment regime having 2 of these drugs with additional drugs also. So, that would be the best answer for this question. One more point I want you to remember at this time is, we can also give prophylactic CNS therapy with intrathecal methotrexate, because some of these children can have a subclinical CNS involvement also. For that purpose, you can use intrathecal methotrexate also. So, based on the information I have given, for ALL, the initial treatment should be a regime containing prednisolone and vincristine. That would be the answer for this particular question. Moving on to the next question. An infant is presenting with respiratory distress. He has a previous history of recurrent respiratory infections. What is the diagnosis? So, it's a small baby with recurrent respiratory infections and respiratory distress. your entire diagnosis is going to be based on the imaging findings which are given. What you can see in the image is multiple, in the CT first, is multiple rounded cysts like this present inside the lung parenchyma. Even in the X-ray also you can see the similar round air-filled cyst inside the um, lung fields. Okay, right. So now what should be the possibility? Now if you look at this question, options of the question, two possibilities can be very well considered. One is CDH, that is congenital diaphragmatic hernia, which is also characterized by cystic spaces inside the lungs, which is nothing but the intestinal shadows inside the lung fields. Then the third option, congenital pulmonary adenomatous malformation. It was previously called CCAM. What is that? C stands for congenital cystic adenomatous malformation. That is also characterized by cyst inside the lung fields. Okay, right. Now, closed differentials are these two options only because they are the ones which are associated with cyst inside the lung fields. Okay, right. Now, how to differentiate between the two conditions? Look at the diaphragm border. Look at the diaphragm border. In the X-ray, I will discuss. Here is a well-defined diaphragm border which is noted. If it was actually a congenital diaphragmatic hernia, you will not be able to appreciate the diaphragm border, okay, due to defect in the diaphragm. But here, I am able to make out a well-defined diaphragm border. So, the possibility of congenital diaphragmatic hernia is very low, or I can exclude that particular option in this question itself. So, that brings us to the answer for the question. It is congenital pulmonary adenomatous malformation. We have discussed this in one of the modules also under airway malformations. There I have mentioned this condition name also, congenital pulmonary adenomatous malformation. Just quick recap of the important points. It is the most common cause of cystic lung disease in newborn. So, if you have a small baby who is having multiple cysts inside the lungs and it is proven that it is only confined to lung parenchyma, you have to think about the possibility of CPAM. CPAM is nothing but an abbreviation for congenital pulmonary adenomatous malformation. It is usually considered as a hamartomatous lesion and it is typically unilateral, most commonly involves the left side of the lung. Even though in the question it was on the right side only the X-ray picture, but most common by statistics wise it is on the left side. Okay. Then the third point is it can present with respiratory distress and recurrent respiratory infection. That is what exactly was given in the question. Now, a most important clinical point is there is a risk of malignancy, either sarcoma or carcinoma in the cystic areas. So, that is why all these children, they require resection of the malformation before 1 year of age. This is something very important. Okay, right? Why? Because especially because of the risk of malignancy, all of these children should undergo resection before the age of 1 year. So, with all the discussion points, answer for the question is option C, congenital pulmonary adenomatous malformation. The key feature in this question is how do you differentiate between diaphragmatic hernia and congenital pulmonary adenomatous malformation. Remember, in diaphragmatic hernia, the diaphragm outline will not be preserved, but in CPAM, the diaphragm outline will be preserved. That is the important thing. Moving on to the next question is one of the repeatedly asked questions in the section of pediatrics. A girl child presents to you with the following deformity. Let us see the deformity from this picture in the lower limbs. You can see the one leg is deviated medially like this, which is what you call it as a varus deformity, and the other leg is deviated laterally like this, which is called as a valgus deformity. What do you call this combination of varus and valgus deformity? It's called wind swept deformity. Wind swept deformity. When a growing child presents with this type of varus and valgus deformity of the limbs, you have to suspect the possibility of rickets, which is a likely possibility in this particular question also. Let us read further. Serum calcium levels were normal, phosphate was low, parathyroid hormone was normal, alkaline phosphatase is increased, and there is a normal LDH. What is the diagnosis? First of all, 4 options are given. VDDR is nothing but an expansion for vitamin D dependent rickets, type 1 and type 2. Third option is hypophosphatemic rickets, also called familial hypophosphatemic rickets. And the fourth option is nutrition rickets, which is a typical vitamin D deficiency rickets. First of all, let us see, is it nutritional rickets or the typical vitamin D deficiency? It is very unlikely or not the answer for the question because of 2 reasons. In nutrition rickets, there will be increased levels of parathyroid hormone, not normal. Okay, it is very clearly given in the question that PTH was normal. Okay, in fact, remember, in a typical or nutrition rickets, you can get normal levels of calcium, but that is under the influence of increased parathyroid hormone. Please don't forget that. So PTH was normal will help you to rule out it is not nutrition rickets. Now we are left with three options. All these three options come under the category called refractory rickets. Correct? Comes under the category called refractory rickets. I have already told in the main videos that whenever you encounter a condition of refractory rickets, you have to approach based on the biochemical investigations only, right? And this is what I have taken in the main videos also. I will repeat it quickly one more time. Okay, this is for refractory rickets. That's what you have to remember. Let us start. In refractory rickets, the first investigation to be done is serum phosphate, and there is only one condition where you will get high serum phosphate. What is that? CKD associated rickets. Because in chronic kidney disease, the kidney is not able to excrete the phosphate outside, so that is why there is high levels of serum phosphate. In all other situation, you will get low serum phosphate only. Then you can do ABG, arterial blood gas, to rule out acidosis. If acidosis is present, then the only possibility is RTA. What is that? Renal tubular acidosis. If acidosis is not present, then we will go down based on the PTH we can try to differentiate. High PTH and normal PTH. High PTH is encountered in situation of vitamin D dependent rickets, and normal PTH is encountered in familial hypophosphatemic rickets. Familial hypophosphatemic rickets. Okay. Now, in this question, if you have observed, it is clearly mentioned that there is low serum phosphate as well as normal PTH, which brings us to the answer for the question as familial hypophosphatemic rickets. So, for this particular question, the answer is option C, which is familial hypophosphatemic rickets. So, that was about the questions which are asked in session 1. We now move on to the session 2, and also I have few miscellaneous questions which we are not able to clearly define as session 1 or 2. That is also included under this session 2 discussion only. We'll start with the first question of this session number 2. A newborn presented with difficulty in breathing. On examination, heart sounds were heard in the right hemithorax. Okay, so the heart sounds are shifted to the right side. Gurgling sounds were heard on auscultation on the left side of the thorax. Now, when you have this combination, okay, heart sound shifted to the right side and gurgling sound, it refers to the intestinal sounds which are heard on the left side. The combination will tell you that it's possibility of CDH or the congenital diaphragmatic hernia, which commonly occurs on the left side. Now, radiographic image has confirmed that in fact it is CDH or congenital diaphragmatic hernia only. The question is, what is the most common site of defect in this particular condition? We all know that the most common type of CDH is Bogdalek hernia, and the Bogdalek hernia commonly occurs on the posterolateral side. And on which side, right side or left side? It's on the left side. So, for this particular question, the answer is going to be option C, left posterolateral. Okay, right? So, I'm not sure the exact stem of the question, but even with the clinical data itself, we can clearly identify that it's a case of congenital diaphragmatic hernia. Bogdalek is the commonest type, so the answer is left posterolateral. Yes. Moving on to the next question. Which of the following should not be done shortly after normal delivery of the baby, right? It is something related to essential or a normal newborn care. Skin to skin contact with the mother, early breastfeeding, eye care using wet swab from medial to lateral, and bathing the baby with warm water. You know that skin to skin contact with the mother is always a preferable one to provide warmth to the baby. So, that is something which is definitely done. Early breastfeeding is also important because we say that as early as possible, the breastfeeding should be initiated after birth. So, that option is also correct. Now, confusion is between the two options. Eye care using wet swab from medial to lateral, bathing the baby with warm water. These are based on the national guidelines given by AIMS Institute, where it is clearly mentioned regarding the option C that eye cleaning can be done with a swab. Wet swab means something which is soaked in a normal saline or a sterile water from the medial canthus to the lateral canthus. They have mentioned it can be done. Okay, so this is a correct option. That brings us to the answer for the question. Bathing the baby with warm water after birth immediately is not recommended because you see the guidelines. It is clearly written, for the bathing after birth, evidence suggests that delaying the first bath until at least 24 hours of life may prevent hypothermia and reduce the mortality risk. So this is not something like bathing is not something which you should do immediately after birth. You have to wait at least 24 hours. So our answer for the question is option D, which is a question from the normal newborn care. Moving on to the next question. A 6-week-old neonate presented with repeated episodes of non-bilious vomiting. Ultrasound picture is shown below. What is the diagnosis? This is one of the frequently asked questions. Okay, right? What is that? You can see that this is the ultrasound showing the stomach outline, and this is the narrowed pylorus channel, and this is showing the thick or hypertrophied pyloric muscle. So what is the answer for the question? Out of the 4 options, it is a clear case of IHPS, idiopathic hypertrophic pyloric stenosis, which is due to hypertrophy of circular muscle fibers of the pylorus. Circular muscle fibers. Okay, right. In fact, we have already discussed this previously also with the same picture only, that ultrasound is the investigation of choice for the diagnosis of IHPS, and by ultrasound we even have a criteria. What is the criteria going to be? 2 things. One is the thickness of the pyloric muscle more than 4 millimeters, and second is the pyloric channel length which is more than 16 millimeters. If it is satisfying, we can make by ultrasound itself that it is a definitive diagnosis of IHPS. So the answer for this question is IHPS. Some of the students also recalled that the similar scenario was given but with some X-rays, and the X-ray was showing a single bubble related to air shadow in the stomach. So only one air shadow was present in the stomach. That is also suggestive of IHPS. So there are 2 variations of this question. One was based on ultrasound, another one was based on the X-ray. Ultrasound, you will directly see the abnormality. In X-ray, you will see the single bubble sign. Both are suggestive of IHPS. That is a point to be noted. Then moving on to the next question. It's again a repeatedly asked question. 2-year-old boy is brought to the pediatric OPD for growth retardation. On examination, significant hepatomegaly is noted with anemia and bone pain. Bone marrow examination reveals macrophages with a crumpled tissue paper appearance. What is the underlying deficiency in this particular child? Okay, as I told you, for the last 1 or 2 NEET-PG exams, this question has been repeatedly being asked, and the same clue is being given in almost all the exam. What is that? Crumpled tissue paper appearance on the bone marrow examination. This crumpled tissue paper appearance of the cells is called Gaucher's cells, and the disease is called Gaucher disease. This is what you have to remember. It is called as a Gaucher's disease. Okay, that would be the answer, that would be the diagnosis in this particular question. The question is not asking about the diagnosis, but is asking underlying enzyme deficiency in this child. Is it hexosaminidase A, sphingomyelinase, glucocerebrosidase, or glucose-6-phosphatase? It goes without any doubt. The answer is glucocerebrosidase. That is the enzyme deficiency in Gaucher's disease. Okay, so please don't forget that it's a repeatedly asked exam question. Crumpled tissue paper appearance of Gaucher cells. In a floppy infant with recurrent episodes of hypoglycemia and evaluation revealing cardiomyopathy, what is the likely diagnosis? Pompe's disease, von Guericke disease, Epstein's anomaly, and McArdle's disease. You can see that in this particular question, there is cardiomyopathy. That means definite involvement of cardiac or the heart involvement. Along with that, hypoglycemia is also noted, and floppy infant. Floppy is something like extreme hypotonia in the baby, like that, right? Now, which of this will be the likely diagnosis? You see, McArdle's disease is one of the muscle glycogen storage disorder where only skeletal muscles are affected. Skeletal muscles are affected. There is no cardiac involvement there, so it cannot be the answer for the question. Epstein's anomaly, of course, we all know that it's one of the important congenital heart diseases, but that will not cause a floppy infant. So that is also ruled out in the question. Next is about the von Guericke disease. Von Guericke disease is a type of liver glycogen storage disorder which presents with repeated episodes of hypoglycemia, but there is no reason to cause cardiomyopathy or floppiness in the baby. So that is also ruled out. That brings us to the answer for the question, that it is Pompe's disease. Pompe's disease is also classified under glycogen storage disorder, but a special feature of Pompe disease is not only skeletal muscles are affected, it is also the cardiac muscles which is affected. And this cardiac muscle involvement is the reason for cardiomyopathy in this particular baby. Okay, right. So just a quick recap of the Pompe's disease. It's characterized by deficiency of alpha glucosidase, also called as the acid maltase. It is also one of the lysosomal enzyme. So classification, it can also be classified under lysosomal storage disorders also. And as I already told you, it is the involvement of skeletal and cardiac muscles. And because of early involvement of cardiac muscles only, a lot of complications can occur and death also occurs in the early age for these children. And the third important point is they can also have associated problems in the form of macroglossia as well as feeding difficulties. Now, involvement of skeletal muscles is the reason for floppy infant as well. It's an extreme involvement of skeletal muscle. So, there is an extreme hypotonia resulting in floppy infants. An important point to be noted is the acid maltase enzyme is also available for ERT. What does ERT stand for? Enzyme replacement therapy. So, this is a quick recap of the points, relevant points for Pompe's disease. That would be the answer for this particular question. So, with that, I have completed the discussion of pediatric questions which are asked in this NEET-PG 2024 exam. Now, I have tried to discuss based on the information regarding the question stem as well as the option which were recalled by the students who have actually attended the exams. There can be slight variations which are possible, and if you feel there are any variations, you can let us know in the comments below. And this exam emphasizes one thing mainly. What is that? You know about a topic, but you have to read the topic properly, because it is the clinical presentations which were given emphasis so much in this exams. And if you know a topic properly only, you will be able to correlate the scenario clinically and arrive at a possible diagnosis. So with that note, I am going to end this session, and also best wishes for those who are preparing for the upcoming exams. Thank you.